What is up, y'all? We are coming today with a don't misdiagnosis. So we're going to talk about spine infections. So before we start, make sure to become a subscriber. And yeah, this is an MRI which we will discuss. That is actually one of these infections of the spine, vertebral bodies. You can see has signal abnormality. So we discussed non-specific mechanical back pain already in the previous video, spinal stenosis, disc herniations. So go back and watch those. This is video 5. So lecture 5, we will discuss today 3 types of spinal infections: vertebral osteomyelitis, discitis, and epidural or paraspinous abscess. So do not miss these. All right, you can't miss these, y'all. Osteomyelitis. So this osteomyelitis is found in many places of the body, or can be, right? 5% of these infections are found in the vertebral column, and that's when you get vertebral osteomyelitis. And the most common type of vertebral infection is this, and it can lead to more invasive infections of the spine. So this is something you don't want to delay a diagnosis and treatment. So osteomyelitis is inflammation of the bone, usually caused by infection, and non-specific clinical presentation can result in delayed diagnosis and severe complications. You can see these vertebral bodies are inflamed. They don't look healthy. They look kind of mad. So that's what we are going to be discussing. So how does this occur? Localized trauma, inflammation, trauma, post-surgical infection, acute infection. Staphylococcus aureus is the most common bacteria that can do this. And usually these are spread from the bloodstream. Also chronic infections of osteomyelitis can be seen in tuberculosis and brucella, and more rarely you can see a fungal osteomyelitis of the vertebrae. So here's MRI, X-ray. The MRI, you can see this low signal in the two vertebral bodies. Usually you have 2 vertebral adjacent bodies affected, and this is a T1 weighted MRI because the CSF is low signal. Spinal cord is a little brighter, and the vertebral bodies are a little brighter, but this one is dark. So, well, 2 of them are dark here at the inferior portion of this one and superior portion of this one. And that's L3 to 4. And here's the sacrum. All right, so when you have the patient there, you want to find out the duration of symptoms. And these can be acute, progressive, or chronic, depending on your organism that's causing this and what's going on. The onset's usually insidious, so slow. It kind of builds up, and it can have slow to rapid progression. Of course, you know, usually these are going to get worse, right? But it can be slow or rapid depending on the cause. So these patients will have back pain, non-specific or absent early in the disease, but usually localizes to affected vertebral level, and pain will often wake the patient from sleep. The location of pain usually settles at site of infection. Aggravating factors, I couldn't find any because even there are no relief with rest. So, you know, even resting, you don't get relief. So, associated symptoms: fever, chills, fatigue, and if chronic infection, may have night sweats, weight loss. Typically no neurological deficits, but we will see this in spinal epidural abscess, which is our 3rd infection we will discuss. Pertinent risk factors: IV drug use. Don't be doping up drugs, y'all, because you can get bacteria into the veins and go to your body and heart and everywhere. Immunocompromised state, prior spinal surgeries, especially retroperitoneal intraabdominal infections, pyelonephritis, kidney infection, diabetes, malignancy, malnutrition. I always ask the patient if there's something they're worried about and prior evaluations they've had. Here is, look at this. Well, actually, we're going to go over this in a bit because this is this is discitis and osteomyelitis. But so physical exam: fever, chills, night sweats. Well, they'll tell you they've had some night sweats, chills, but you'll note fever probably. Maybe not though, but probably. Back inspections usually normal. Palpation, no tenderness at the affected vertebral level. Range of motion can be limited, and usually you won't see any neurological deficits. But this is serious because it can lead to that, right? It can lead to worse complications. So this is a don't miss diagnosis. Of course, MRI is like a big scan to order. You have to get insurance to prove it and just a lot of stuff. So sometimes you might just want, if you don't have a high suspicion, but you have suspicion, you might want to be safe, get the MRI, or can order these lab tests. Thankfully, these have very high sensitivity. Almost every patient with vertebral osteomyelitis will have a high ESR, or sedimentation rate, and a high CRP, C-reactive protein level. So high negative predictive value. If these are negative, high chance the patient does not have this going on. White blood cell count is less sensitive, surprisingly, is normal in less than half of patients even, 40% it can be normal. And blood cultures should be taken, again, they can be normal, but usually these are spread from the bloodstream, hemato, blood, and then genus originating from the bloodstream, dissemination. And if you're considering this diagnosis, just get the MRI ASAP. Don't prolong that. And plain radiographs are insensitive to diagnose vertebral osteomyelitis, so don't waste your time there if you have high suspicion of this. And you can see this is T2 weighted, this is T1 weighted, and T1 weighted plus contrast. So what's going on here? T2 weighted, fluid is bright, CSF is bright, spinal cord is darker, vertebral bodies are usually dark, but here these are bright. This is where the osteomyelitis is. T1 weighted, CSF is dark, spinal cord is a little bit brighter than that, CSF, and then the vertebral bodies are lighter than on T2, and here these vertebral bodies are dark. And then post-contrast, we see some enhancement at the borders, the inferior superior border of these that are affected vertebral bodies. And the disc is pretty much crushed here, intervertebral disc, as well as here, narrowing disc space. So, infection of the disc, this is discitis. So this is when the disc, intervertebral disc between the spinal vertebrae become infected. Right here, when these become infected, the disc. Then this usually is a complication of vertebral osteomyelitis. So you have the hematogenous bacterial spread to the vertebrae, and then that can spread to the disc. And this is very bad because we'll discuss why in the next couple slides here. But this is bad because right here, the discs are avascular. So if you can't get a lot of blood vessels going there, how are you going to get antibiotics there? Now, somehow they end up working. I'm not sure how that works, but it's a long process of intravenous antibiotics. So discitis is most common in the lumbar spine, then cervical, then thoracic. Children have a more acute onset than adults would. Children may have back pain, refusal to walk, and even may complain of abdominal pain. Adults have a more prolonged and slow development of symptoms, usually, including back, neck pain, fever, weight loss, loss of appetite, or neurological deficit, which is rare, but it can happen in this case. We discussed it's rare. Back pain usually is localized at this level without radiation to other areas. That's where we're going to say it's rare. So you're going to examine the patient and you're going to note point tenderness, range of motion, but will be limited and painful. Lower extremity muscle strain sensation and reflexes usually are reserved, but in a small percent of cases, neurological deficit may be seen, but not too common. Again, CRP, ESR increased, white blood cell count may be increased, may not. Blood cultures may be positive, may not. Plain film, probably wasted time. It's going to take weeks to show this on plain film. X-ray. So just get the MRI done, and you'll see this is a case, two cases actually, different cases of vertebral osteomyelitis concurrent with discitis, or however you pronounce that word, discitis. So you see the vertebral bodies are infected, and the disc, can't even really see the disc here, it's just destroyed. Here, not sure if this black thing's the disc and this is fluid, or if the disc is bright with fluid. CSF has fluid, this is T2. CSF is fluid, it's bright here, T2 weighted MRI. And here, these are bright, right here, brightness on these vertebral bodies. So this is osteomyelitis, and some discitis here. And this is actually a T1 weighted image here, which is why these are darker here, the disc. The bodies of vertebrae. Here, they're brighter here and here. So yeah, long-term IV antibiotics will be needed, and less commonly surgical intervention. 90 to 95% survive this, so it's still pretty bad, but a lot of people survive. But yeah, usually, what's the difference here? Fever, chills, night sweats, they both can have this. They both can have tenderness. They both usually have no neurological deficits. This pretty much definitely doesn't have neurological deficits. This might have neurological deficits. But other than that, it feels like they're pretty similar. So it might be worse in pain though, or severe pain. Now this one is the one, y'all, that is really devastating, and you don't want to delay this diagnosis. Infection of the epidural space can lead to devastating neurological deficits. Thoracic and lumbar spine, most common locations. So this is our epidural space right here, right anterior to this ligamentum flavum. So you have your subarachnoid space, epidural space, and this blue is the dura. So the blue thing's the dura, and outside of the dura is the epidural space. You get an abscess in there, you are crushing the spinal cord. You are getting paralyzed, okay? This is not good. You know, this is bad stuff. So, fever, back pain, and really brisk neurological deterioration. So these patients can deteriorate within days. Although I've had one person I know of who just had some back pain for a couple of weeks before things deteriorated. Usually this is a week-long thing, and it's paralysis. So it's nothing to mess around with, but don't just, shut yourself into this triad here. If this triad is here, no excuse, get the MRIs. This is high suspicion. But just back pain, atypical, very bad, follow up these patients. Because you don't want to delay this. So you have this buildup of pus in the epidural space, right? And it's building up, it's growing, it's enlarging. And it can directly damage the spine by compression or ischemia. You have blood vessels in here, ischemia can occur, so double damage. Anterior abscesses likely came from extension of vertebral osteomyelitis. So this is a posterior abscess. If you have an anterior abscess, it's probably spread from osteomyelitis back. These might be from some other cause. But here is a posterior spinal epidural abscess, and you can see MRI, this is a T1 plus contrast. Spinal fluid is darker. And what's interesting is, actually, is this a spinal fluid? Yeah, this is a spinal fluid. This is thoracic spine. And this is the spinal cord in lighter gray. And this is the spinal fluid in a dark color, low signal. And this is the abscess, which is also dark. So you need IV contrast. Why? Because this bright signal is contrast surrounding the abscess. It will peripherally encase this abscess when you add the contrast. Because without contrast, it will be harder to differentiate the fluid from the cord from the pus. This pus is fluid. We have a PO or what? Oh my. I gotta move. Yeah, I don't want to be making a video on wasp stings next or bee stings. And I don't want to be the patient. Okay, so now I can't even see the screen because it's so bright out here. But basically, this was the MRI, and you can see how this extends in the epidural space. So if the patient has this triad, severe back pain, fever, neurological deficit, you are going to have to think SEA and get the stat MRI with and without contrast. If you delay this diagnosis, devastating outcomes for the patient, because once neurological deficits set in, they're irreversible. Okay, it's not coming back without a miracle. So 4 stages of progression. These usually will progress over a few hours to several days. So pretty quickly, back pain, fever, spinal tenderness at first. Then radicular pain radiating from level of affected spinal nerve. You'll have some neck stiffness maybe if you have, I don't know why, but nuchal rigidity. And hyperreflexia. Reflexes will be excessive. Then 3rd stage, neurological deficits. This is the stage you don't want to get to. Loss of sensation, motor weakness, bowel bladder dysfunction. If it gets to this stage, the patient may never be able to urinate or use the restroom again without, catheterization and other things, ileostomy, and they might have loss of sensation. And if this is high up in the C-spine, breathing, they could live on, mechanical ventilation. Loss of arm use and legs, paralysis. If it's in the lumbar, spine, or thoracic, it might just be lower limbs. Either way, this is not something you want to, miss. The SEV rate, thankfully, ESR, CRP, they're elevated in nearly 100% of cases. So if these are normal, you feel pretty good, okay? But if they're abnormal, MRI with and without contrast, gold standard. And if they have this triad, just get that MRI. Delay is unacceptable in these cases. And white blood cell count in cultures can't be relied upon. Many may be normal. So here's the anterior SEA. Okay, I think we're safe now. Anterior, and these can extend here. This looks like osteomyelitis, and they extended posteriorly. Now here's a posterior epidural abscess. So both of these can crush the spinal cord, right? And you can see it here. Now this is great. You have the axial. Okay, this is our sagittal axial MRI. You can see this bright pus-filled abscess right here in the right side. Well, actually, this would be on the left side because it's the right side of the MRI image. So it's the left side of the patient's body. That's how they usually orient these things. So this would be a left-sided posterior epidural abscess, right? And of the spine. So they look very similar. Okay, and that's the end of this video, y'all. We out. Thank y'all for watching. We got this. Have a great week. Make someone smile again.